Welcome.
Thank you, and thanks for the introduction. Well, good afternoon, everybody. Welcome back from lunch. Thanks for coming back out. I would like to start, like many of the other presenters, and just thank Julian and Sebastian for the invitation. Appreciate the opportunity. It's been a nice time and a nice visit so far. I'm just glad to be among these presenters. So, as you can see from the title of my talk, this afternoon I'd like to talk to you about this phenomenon called cardiovascular drift and how it relates to maximal oxygen uptake, or VO2 max, that I'm sure you're all familiar with, but especially during heat stress. Now, the relation between this phenomenon and VO2 max has really various implications, lots of different things that I could talk about. I've studied various aspects of this relationship, but what I'll focus on particularly for today are implications for exercise prescription. So I'll try to keep the session very practical. We've already had some really good sessions on cardiovascular physiology during exercise in the heat, so I'll try to keep mine very practical and really stick with the implications that I believe this has for exercise prescription. So with that in mind, just want to give a quick, brief overview of exercise prescription, maybe for those who are perhaps less familiar with some of the ways in which we try to prescribe exercise. So there's, I suppose, different ways you could approach this, but one way that I'm familiar with, and I think that the American College of Sports Medicine sort of endorses, is use of this acronym that we call the FIT acronym, or FIT principles. So each of these letters stand for a concept that we can use to approach exercise prescription, so I'll just go through these quickly. So the F stands for frequency, which refers to the number of sessions per week, or the number of days per week that a person would be expected to exercise as part of a program. The I stands for intensity, so how hard a person would be expected to exercise as part of a program. The first T that you see there stands for time, which is referring to the duration of the exercise. So how long per session a person would be expected to be physically active. And then the last one there, the last T, refers to the type or the mode of the exercise. So each of these are important in their own ways, particularly the first three of these concepts, if you will, are important in determining the overall volume of the exercise that a person may accumulate throughout a program or throughout a week's worth of programming and so forth. So while they're all important, the one that I'll focus on for the purposes of this session or this talk is really just intensity, because I think that's the one that relates most to heat stress. So let's talk then a little bit about an overview of exercise intensity prescription specifically. So intensity can be prescribed a variety of different ways. One that I'm sure you're most all familiar with, that's been alluded to in some talks already, is RPE, or rating of perceived exertion. So you've probably likely seen this scale before, developed by Borg many years ago, where a person can rate a subjective intensity based on the verbal anchors there. They can sort of pick a number. And so intensity could be prescribed this way, where it's more subjective based on the person's preferences, but still you could use ranges and prescribe intensity that way. Also, though, what's often used is heart rate, utilizing a heart rate monitor, as you see pictured here, which again, I'm guessing most in this audience are probably familiar with. And of course, the way this works is an individual wears a heart rate monitor strap around the chest, and as they do that, it transmits the heart rate to a wristwatch receiver. So let's talk a little more about just a variety of ways of prescribing intensity and kind of put heart rate into perspective here. So this is a table that's included in the American College of Sports Medicine guidelines for exercise testing and prescription. So it's kind of busy. Let me orient you to it a little bit. So I won't spend time going over all these methods, but just to kind of orient you to the table. So along the top, you've really got a variety of the different ways of prescribing exercise intensity. And so a lot of choices here. That's one of the nice things about, I think, prescription, is you try to make it very individualized, and in order to do that, you kind of have to have a lot of options. So it could be based on absolute MET levels, basically multiples of the resting metabolic rate. It could be based on MET levels, but with a person's max capacity in mind, so sort of relative to their max capacity. We've got absolute intensity recommendations based on age, and then of course there's RPE again that I just talked about. But then over here we see some ways of prescribing exercise intensity based on heart rate as expressed as a percentage of heart rate reserve, or as a percentage of heart rate max. And of course, we've got likewise ways of prescribing intensity based on percentages of VO2 reserve and percentages of VO2 max. And if you're not familiar, heart rate reserve just factors in resting heart rate into the calculation. Likewise, VO2 reserve factors in VO2 at rest as part of the calculation. So the nice thing about this is it works kind of conveniently. If you need sort of a guideline to prescribe exercise, you can decide what level you would want a person to exercise at based on these categories on the left-hand side. And then you've got ranges in which that you can work or prescribe the particular session or the program, whatever it happens to be. So again, let's focus on heart rate, though, for the purposes of this talk. And so why then, besides the fact that I've already mentioned heart rate is fairly inexpensive, these heart rate monitors that I showed you in the previous slide, while they can get really fancy and very expensive, in their simplest form, they're actually not that expensive. They can be used under a variety of conditions. So they are pretty easy to use. They are fairly inexpensive. But what else is it about heart rate that makes it something that we want to use for exercise intensity prescription? And that is likely because of its nice linear relation to oxygen uptake or to metabolic rate. And there's been a variety of studies that have demonstrated this. I just happened to choose one of them. These data are by David Swain, who's at Old Dominion University, and Lutholtz back in the 90s. And these are really reflective of a lot of the studies in this area where they've essentially taken individuals, had them perform a number of graded exercise tests, and looked at their heart rate response and their VO2 response throughout that exercise. And so in this particular case, you see the scattergram of all these graded exercise tests performed by various individuals, and so they've related heart rate to VO2. Now, they actually related this in a lot of different ways, just heart rate relative to VO2, percent heart rate max relative to percent VO2 max, and so forth. They happened to find the tightest relation when they related percent heart rate reserve to percent VO2 reserve. So that slope there you see is kind of a 1-to-1. So it's kind of nice if you want to prescribe intensity for someone at say 60% of VO2 reserve. The nice thing is that corresponds to 60% of heart rate reserve generally. So it's this nice kind of 1-to-1 relationship. Point that I'm trying to make is there is this nice linear relation between these two, and so that means heart rate is kind of a nice tool for exercise intensity prescription. Now that said, these data and others like them were based on graded exercise for the most part, graded exercise test of a fairly short duration. So we're not talking prolonged exercise here. And so it really leaves the question a little bit unclear as to how do these variables relate for exercise that's more prolonged, for exercise that's more than just kind of a graded exercise test that may only last 10 to 12 minutes or something like that. So let's talk about that now. These are some data. There's actually a variety of studies I could have chosen here that show cardiovascular responses over time. I just happened to choose these. It's a paper that came out not too long ago by Joel Trinity, who was a former PhD student in Ed Coyle's lab at University of Texas at Austin. And their lab has done a lot of nice work in this area, looking at cardiovascular drift. And so what are these cardiovascular responses over time when we look at heart rate? So let's focus on the top graph. So we've got heart rate. And what Joel had these individuals do, this was cycling exercise at, I believe it was around 57% VO2 max under a normothermic condition. And so they measured heart rate. They also measured stroke volume using acetylene rebreathing over this same time period. And so you see this nice increase in heart rate as you'd expect from baseline. And then heart rate starts to kind of reach some level of steady state where you would think it would kind of level off. But the scale maybe is you can't see it real well, but you can hopefully appreciate that the heart rate doesn't completely level off and just stay constant, even though the exercise intensity is not changing. So we're talking this is a constant level of, like, say, power output that's not changing, but yet, despite that, the heart rate continues to drift upward over time, probably somewhere around 10 beats or so, maybe over this 60-minute period. Meanwhile, stroke volume is progressively decreasing over time. So after the initial increase from baseline, it begins to progressively go down over time. So this is essentially what we mean when we say cardiovascular drift. So if you're kind of looking for a definition, this is the definition, this sort of progressive increase in heart rate and progressive decrease in stroke volume over time during constant rate, typically moderate intensity exercise. All right, so it certainly has been shown to occur in more normothermic or neutral, thermoneutral, if you will, conditions, but greater effects tend to happen under hot conditions. So in the same study, these investigators had individuals perform the same exercise while hyperthermic. And once again, you can see in now the open triangles, the heart rate follows a similar trend, but the magnitude is greater. So a greater increase in heart rate over time, greater decrease in stroke volume over time, essentially making the point that drift occurs during prolonged exercise, greater effects tend to occur in hot conditions. So where I come into all this, actually, let me just say, we found similar results. These are data from Andrew LaFrenz, which was a student in the program when I was working on some of this during my PhD work. And this particular study, we had individuals exercise for 45 minutes. We looked at cardiovascular drift essentially between the 15 or so minute mark, because by definition, drift is kind of this idea that it starts after about the first 10 to 15 minutes of exercise. And so we looked at it between 15 and 45 minutes of this period of cycling exercise with at 60% VO2 max. And the point I'm making here is we found similar results as Trinity in terms of under hot conditions. So we had individuals in a cool environment that was around 22 Celsius, had individuals perform the same exercise in 35 degrees Celsius, which was our hot condition. And we found similar results, bigger effect, bigger magnitude of drift, a bigger decrease in stroke volume, bigger increase in heart rate in the hot condition. And this is kind of what the setup looks like. We have the CO2 rebreathing technique that we use to get cardiac output, which you can then use to get stroke volume. And of course, just a heart rate monitor for heart rate. So where I come in, though, to this is really wanting to understand, well, what does it matter? Is cardiovascular drift sort of just this phenomenon that happens, but it doesn't really matter? Or does it have some sort of consequences that we need to maybe pay more attention to? Does it perhaps even have negative consequences that affect things that we could be interested in? And so that's some of the work that I've focused on over the years. So to explore this, we have conducted a number of studies really using the same protocol that I just described. Individuals perform cycling exercise for 45 minutes, typically in a hot environment, 35 degrees Celsius, 60% VO2 max. And we measure cardiovascular drift between the 15 and 45 minute time points. And then we also measure VO2 max at the end of the 45-minute exercise. So a person goes right into a graded exercise test to measure VO2 max. So we sort of have a VO2 max, if you will, value at 45 minutes. On a different day, they perform 15 minutes of exercise, measure VO2 max again at the end of that. So now we sort of have a VO2 max value at 15 and at 45, so we can compare drift and max over the same time interval. Ideally, we would measure max at 15 and then again at 45, but you can't really measure VO2 max twice in the same exercise session. So we kind of do it on a different day, but the conditions are identical. So that's our protocol, that's our paradigm. And then we manipulated drift a variety of different ways in a number of different studies, using high body temperature, using manipulations to exercise intensity, in which we tried to kind of lower the intensity to attenuate the drift, to keep heart rate more constant. We've used body cooling, where we blew a fan on an individual or on individuals to blunt the rise in core body temperature and thereby attenuate the rise in heart rate over time, versus a condition in which we didn't do that. We've utilized hydration status. Now, this was the one study that actually used a slightly different protocol. The temperature was a little lower. It was 30 Celsius, and the time points were 15 versus 60 minutes versus 120 minutes, utilizing keeping the participants euhydrated or allowing them to become dehydrated, and then again looking at the magnitude of drift as well as effects on VO2 max. And then we've also used ambient temperature, which were the data I just showed, where we had cool versus hot environment, looking at this same relationship. And what we found was this consistent relation. So if you plot all of our participants in all these various studies and look at the change in stroke volume. So this is the change in stroke volume between 15 and 45 minutes, expressed as a percent change. And then we have the change in their VO2 max from 15 minutes relative to 45, again expressed as a percent change. And you see this directionally similar and essentially proportional change in VO2 max as related to stroke volume. So the point here is the larger the magnitude of drift, in this case reflected by stroke volume, the larger the decrease in VO2 max, the bigger the percent change in VO2 max. So there does seem to be, it does seem that that cardiovascular drift is not just this benign phenomenon that we should ignore. It actually has implications in how maybe it relates to VO2 max. Now, this really beyond the scope of today's talk to get into the mechanisms of this and to explain why I think drift relates to VO2 max, but I'll just suffice to say that we believe the reduced stroke volume that's occurring during the submaximal period is persisting during maximal exercise, such that perhaps stroke volume is going up some, but not enough to reach true stroke volume max. So therefore, VO2 max is compromised. So what implications then does all this have for exercise prescription? Well, here's one way of looking at it. So these are data from one of the studies that I presented. So we've got a change in these different variables from the 15-minute value, again expressed as a percent change. So essentially nothing no change at 15 minutes. But then if we look at, so the VO2, let's start there. So again, this was constant rate exercise. We're not altering the exercise intensity. So that stayed fairly constant over time, as you might expect. Maybe a slight drift upwards in VO2, but not much of anything. Because, though, the VO2 max is decreasing, and we observed it in this particular study about an 18 or so % decrease, and we've seen that consistently across our studies, anywhere from 10, 12, 15 up to almost 20% decreases in VO2 max in this 45 minutes of exercise. So because of that, this now reflects a higher relative metabolic intensity, a higher percent VO2 max. Albeit transient, their true VO2 max is really higher than this, but momentarily it's decreased. So now this is a higher reflection of the relative metabolic intensity. So to kind of put this into numbers for you, this is a little bit busy, but these are data from the same study. Let's just start over here. So we've got percent VO2 max, or these different variables expressed relative to a control test. So just a normal graded exercise test, no prior exercise. And so if you express the absolute VO2 relative to the VO2 max from the control at 15 and 45, you see really no change, very little change. Of course, heart rate's drifting up over time, so you do see an increase in that. It doesn't really matter how you express the VO2. Essentially, it's not changing. But if you rethink this a little bit and kind of acknowledge the way in which we're trying to approach this, well, then it's nice because looking at it over here, it appears that there's perhaps a dissociation between heart rate and VO2. However, if you think of the VO2 max as being momentarily decreased and express VO2 relative to this newly decreased VO2 max, now there appears to be a better relation here. Heart rate is kind of reflecting the relative metabolic intensity. It's reflecting maybe more accurately what's happening with VO2. This is really kind of the same idea, just put a different way. These are data from all these different studies, participants in all these different studies plotted together, and it's essentially just kind of showing the same thing, just a little bit different way. So again, we've got a change in heart rate reserve, or percent heart rate reserve between this 15 and 45 minute period relative to a change in the percent VO2 reserve between 15 and 45 minutes. Again, utilizing the max at 45 minutes. Not the control max as the basis for this calculation. And so you see that there's this nice relationship. Now, it's not quite as tight as the one that Swain had found that I showed you earlier, where they had kind of a one-to-one correlate or slope there, one-to-one relation. But still, it's pretty good. And so the point is, heart rate perhaps is a better reflection of relative metabolic intensity under these conditions than you might have thought if you kind of assume VO2 max isn't changing. So what does this bring us to? What are the take-home points from all this? Well, first of all, under these conditions, when you expect cardiovascular drift to occur, so if you're expecting heart rate to drift upwards over time, there seems to be this consistent effect on VO2 max, at least in our data. So you can expect there's likely to be a reduction in VO2 max. So if that happens, it appears that the heart rate, relative metabolic intensity, or percent VO2 max relationship is essentially preserved. So heart rate really remains kind of a reliable indicator of exercise intensity. And so it can be kind of continued to be relied upon. So in terms of recommendations, what should we do here? Well, I think you've got a couple of choices at kind of the two opposite extremes. First of all, a person could prescribe a constant target heart rate and say, well, I need the person to stay in a certain range or at a certain constant target heart rate, which means, though, they're going to have to slow down. In order to, whether it's running, they're going to have to slow down. If it's cycling, they'll likely have to slow down. They're going to have to reduce their intensity in order to keep the heart rate from drifting upwards over time. And if that happens, it's likely to compromise the metabolic stimulus of the exercise and thereby perhaps the training adaptations that occur. Kind of on the opposite extreme, if you say, well, let's just ignore heart rate then and maintain the absolute intensity, allow heart rate just to drift upwards over time, well then depending upon the person, they might be more susceptible to a heat injury if they're not very well acclimated, or even if they are acclimated and they're going particularly at a high intensity, then they might be at a greater chance of a heat injury. And of course, certainly perceptually, it's going to feel harder as they go along. So they just might decide to stop early and kind of cut the workout off prematurely. So that's a consideration as well. So if you really press me and say, well, then what should we do? I would say I don't know if I have a great recommendation for you, other than to maybe the happy medium is something between these two, between the two extremes. Perhaps find an intensity where you keep heart rate at some range, but not necessarily at the initial heart rate that you started at, and thereby you also help try to avoid heat injury. Okay, so I'll stop there. I would like to just acknowledge that the studies that I incorporate in here were partially funded by GSSI, as well as the Coca-Cola Company. And my co-authors on quite a few of these papers were my PhD mentor, Kirk Cureton, who's at University of Georgia, and Dr. Matt Gagnon, who's at University of Arkansas. This is my lab at Alabama in our heat chamber where I'm currently working. And if any of you think of questions once you leave the conference, there's my contact info if you'd like to follow up with anything. Thanks for your attention. I'll be happy to try to answer any questions.
Thank you very much, Jonathan, for a nice presentation. Is there any questions for the audience?
Thanks, Jonathan. Great talk. We enjoyed it. I just want to ask you a question about one of your final conclusions. Can you just explain a little bit more detail on the bottom one, why maintaining the same absolute intensity might lead to greater chances of heat injury?
Sure. Well, what I mean by that is, say you've prescribed someone to exercise at a certain, let's say, speed or power output in a hot condition, and as heart rate rises over time, well, as the exercise proceeds over time, they're likely to heat up. Assuming this is now, I guess based on some of your data, if it's compensable, maybe a core temperature is going to reach some sort of level. But we've seen, at least in a number of our studies, I mean, core temperature is just continuing to rise over time. So maybe we're at a high enough intensity to where it's not compensable. So that's kind of what I'm getting at. If the core temp doesn't level off and these people are continuing to heat up over time, there's this chance of a heat injury. But yeah, that's the key there. Is it compensable or not? Sure.
Thank you. Maybe just to add to that as well, I think if they are exercising in the heat, obviously there's quite a tight relationship with the rise in heart rate and the rise in core temperature. And at some point, the intensity would become so high that they probably couldn't keep going, so they'd have to slow down.
Right.
I guess my question was, in terms of heart rate reserve and VO2 reserve, you showed a nice tight relationship in both the hot and cool conditions. Mm-hmm. And in cool conditions, there wasn't quite a strong relationship between heart rate itself and VO2. What about heart rate and VO2 in the heat? Is there as strong a relationship as with heart rate reserve and VO2 reserve?
Yeah, I don't remember that graph. I mean, we've graphed it all sort of different ways, and I don't recall off the top of my head what it came out to as far as the correlation and so forth. And I remember it being okay, but those were kind of our best data, so that's why I presented those. But yeah. Yeah. Typically, heart rate reserve. You're right. I think most practitioners will use a percentage of like heart rate max or something to prescribe exercise. It's a little easier. But actually, I think heart rate reserve is preferable because if you have two individuals, let's say, at a similar age, and so you end up kind of with a similar target heart rate. Well, if one person's resting heart rate is say 75 beats per minute, and another one's 50 beats per minute, well, to both reach the same target, it's quite a difference for the person that's at 50 than the person that's at 75 to get to that target. So I think heart rate reserve kind of eliminates that. So I believe it's preferable, but yeah, in true practice, probably more practitioners maybe use the other, but I just have a feeling it's because they haven't thought through that very well. I teach a class on this, so I sort of try to get my students to use heart rate reserve. So, yeah.
It is. I was intrigued for the protocol that you use, the 45 minutes. And my question is, do you have the same effects on VO2 max if you carry on the VO2 max test in a normal thermonuclear environment?
So after the same 45-minute period?
Yes.
So yeah, we did that in the LaFrenz study. I guess I didn't show the individual results of that study, but no, certainly there was, I think, a slight decrease in VO2 max, but a fraction of the decrease that you see after the 45 minutes in the heat. So it really did kind of, and there was a slight cardiovascular drift though after the 45 minutes in the cool. So that relationship really did kind of stick. In other words, small drift, small decrease in VO2 max, large drift, large decrease in VO2 max. So it kind of helped form that relationship.
Thank you. Any other questions? Otherwise, we thank Jonathan for the nice presentation. We move to the next one.